Hello, everyone. Welcome to this webinar. I'm Dr. Matt Hoskins. Your videos are automatically turned off and you're all automatically muted for this webinar as well. If you've got any questions as we go through, if you'd like to click on the chat button and just type them in there, when we get to the end, if we've got enough time, I'll just start going through questions one by one. But hopefully a lot of the questions you might have will be answered by the presentation. So I'll just pop that up so you can see the first slide. So I'm introducing the new Traumatic Stress Wales PTSD prescribing algorithm. And I'm Dr. Matt Hoskins. I'm a consultant psychiatrist. I'm the lead consultant for adults for Traumatic Stress Wales. I've got a split job. I work mostly for Cardiff and Vale, looking after the older wards, psychiatric intensive care units, and then I do some of the national work for TSW, as well as 3 clinics a week for the traumatic stress service in Cardiff, and then in Cwmtaf and Swansea Bay as well. So my conflicts of interest, I always declare. I was the principal investigator for a MAPS-sponsored clinical trial of MDMA-assisted therapy. I've received training in kind and travel expenses for that. And I've also been involved in co-founding a private medical cannabis clinic, and I received payments for consultations. And what we'll cover today, and we've got about an hour. I think we might be able to run on a little bit at the end with questions if that's possible with Teams. But what we'll cover, I'll give you a brief background on the Cardiff prescribing algorithm and how that's now been updated to the All Wales TSW prescribing algorithm. I'll talk a bit about some of the updates in the literature over the past several years. And then we'll go into a bit more detail about the changes to the new algorithm, mostly around individual drugs being specifically labeled as licensed or unlicensed indications. Spoiler alert, there's only 2 licensed drugs for PTSD, being paroxetine and sertraline, so almost everything we use is unlicensed. I'll talk a bit about how I've separated out what can be primary care initiated and what can be or should be secondary care or specialist initiated. We'll talk a bit about the re-emphasis of risperidone. I'll talk a bit about triple therapy when someone's on an antidepressant plus an antipsychotic plus either prazosin or doxazosin. I'll talk a bit of detail about prazosin and doxazosin, the benefits of each and some of the disadvantages of each as well. And I'll give you some pragmatic guidance on insomnia as well. So without further ado, I hope a lot of you would recognize this. This is the Cardiff prescribing algorithm. It was a piece of work led by Prof. Bisson, 2 medical students, and myself some time ago. And the aim of this was to give clarity over evidence-based prescribing in PTSD. And there's been a number of different international and national guidelines on prescribing for PTSD, which don't always agree on each other. So what we aim to do is really give clinicians up-to-date evidence-based strategies, hopefully to improve access to medications that are evidence-based for people with PTSD. So this was based off of a series of systematic reviews and meta-analyses I conducted. The first one was back in 2015, and then we updated them in 2021 in 2 separate papers. These were actually used to inform the International Society for Traumatic Stress Studies prescribing guidelines, and the Cardiff algorithm was featured there. And within the Cardiff algorithm, we had first, second, third, and fourth line options, as well as strategies for augmentation at different stages as well. So just to give you a glimpse of what we'll talk about, this is what the TSW 2024 prescribing algorithm looks like. Couldn't fit it all onto one page, unfortunately, but we have expanded upon the first algorithm and added some more detail, which we'll go through. But if we have a brief glance, we can see that the first line remains unchanged. Sertraline, fluoxetine, and paroxetine. These can be initiated in primary care, and we've indicated what's licensed and what's unlicensed. So there we can see sertraline and paroxetine are licensed. Paroxetine is not licensed over 60 milligrams for PTSD. And then if there's an If this isn't being tolerated or they're still showing clinically significant symptoms, the second line would be swapping or switching to venlafaxine, which of course is unlicensed, as everything is in PTSD apart from those two drugs. And then when we move down to augmentation, once you've established someone on an SSRI or an SNRI, such as venlafaxine, then we have the options for augmentation. And I've broken these down so they are a little bit more explicit. You've got an SSRI or venlafaxine plus quetiapine, or an SSRI or venlafaxine plus risperidone, or an SSRI or venlafaxine plus either prazosin or doxazocin. And then that can then lead into what I've kind of started calling triple therapy. So the bulk of my patients are complex and severe PTSD sufferers, and it's not uncommon for them to end up on 3 medications eventually. So an SSRI or venlafaxine plus prazosin or doxazocin plus quetiapine or risperidone. And then third line, we've got quetiapine monotherapy, and I've expanded upon the ability to augment quetiapine, which wasn't in the previous algorithm, which is quetiapine plus prazosin or doxazocin, because some people might get to the stage where they've been through the antidepressants, they really can't tolerate them for various reasons. You go back to the drawing board, they're on quetiapine monotherapy, but you can still augment that with prazosin or doxazocin. And then in the fourth line, we've got the 3 agents there, mirtazapine, amitriptyline, and phenelzine, which were superior to placebo, but in single studies only of maybe 20 to 30 people in the studies. So much less evidence-based than sertraline, fluoxetine, paroxetine, and venlafaxine. So a little bit of background in terms of the systematic reviews. This is the flow chart from the main one in terms of the numbers of studies that we looked at. We included 115 in the overall analysis. We looked then at studies that were monotherapy, so drug versus placebo, augmentation, which was usually SSRI or SNRI, plus the agent of interest, plus the same thing, but with a placebo. And then very interestingly, pharmacotherapy assisted therapy. So things like MDMA assisted therapy, D-cycloserine assisted therapy. And then we also looked at pharmacotherapy versus pharmacotherapy studies, so head-to-head ones. These are really useful in network meta-analyses. And then pharmacotherapy versus psychotherapy. And just as a bit of interest, this is what the data analysis looks like. This is an example here of the forest plot for paroxetine, where along the left-hand column you've got the names of the studies. The center data points are data points of interest that we extracted. So the mean change in CAPS plus the SD. And then this diagram here is the forest plot. So the horizontal line is the line of no effect. The individual green boxes with the black lines emanating from them are the studies. The bigger the green box, the bigger the study. The black lines are the confidence interval. So the wider the wider the line, the wider the confidence interval. And then the black diamond at the bottom is the meta-analytic outcome. So when you add those studies together, you can see that paroxetine crosses over that line of no effect and is an effective medication, one of the single most effective medications for PTSD. So what we took away from the original systematic reviews is that there's good evidence of a small effect, and that we can recommend these agents to be used by themselves. So the antidepressants plus quetiapine. There were small single positive studies for the 3 agents that are in our step 4. And when we looked at augmentation, this is when you have obviously a drug of interest added to a base drug versus a placebo added to a base drug. There's good evidence that prazosin and risperidone are useful in augmentation. Now, you're probably aware of prazosin. It's an old-fashioned heart medication. It's used to lower blood pressure. And maybe 20-odd years ago, it was discovered kind of accidentally when they were treating, I think it was male veterans with heart problems. And they also happened to have trauma, but they treated them with prazosin and their blood pressure came down, but they also reported that their trauma symptoms improved. And in some people, it seems to target nightmares and then daytime intrusive recollections and then hyperarousal symptoms particularly. For a lot of people, it's just across the board reduction in symptoms. So from the reviews, we know that there are a lot of drugs that were not better than placebo. Very interestingly, we've got some other SSRIs there, including citalopram. We've got another atypical antipsychotic there as well, olanzapine. And this told us really clearly that there isn't a class effect in drugs that treat PTSD. We cannot say that SSRIs as a class are effective. We can't say atypical antipsychotics as a class are effective. We can only say the specific drugs that outperformed placebo, especially in a way that can be meta-analyzed, are effective. And drugs that weren't investigated but are sometimes used in clinical practice included things like trazodone, melatonin, duloxetine, clonidine, doxazosin, for instance, and promethazine. So these are drugs that we sometimes might use but weren't actually tested, and we can't say that they were or were not better than placebo. So in terms of updates from the literature, I spent a bit of time the latter half of last year, moving into this year, looking through what reviews have come out, what new studies might have come out, and I'll just talk through some of them and the ways in which they've affected the TSW algorithm. So Williams et al. Published a Cochrane review and favored SSRIs as a class, saying that they can be used as a class, which goes completely against what I just said. And the reason for that is that they weren't looking at the usual endpoint that we tend to favor in PTSD studies, which is the clinician-administered PTSD rating scale, the CAPS. In this Cochrane review, interestingly, they looked at the CGI-I, the Clinical Global Impressions scale, which is a brief rating scale. It's very subjective. It is not disorder specific. It's roughly saying how much do you think this person has improved from time point to time point. Now, not every study is going to use the CGI, and in fact, the venlafaxine studies that we know of didn't include CGI, so therefore it wasn't reported in this Cochrane review, and venlafaxine was not recommended. Sertraline, interestingly, we know is more effective than placebo when you look at the CAPS, but when just using the CGI-I, it was not found to be effective. So even though they're recommending SSRIs as a class, sertraline, a drug that we do know is effective, was not actually shown to be effective in their study. Then Moes Costa et al. Conducted a really interesting network meta-analysis. And this is where you look at studies that compare to placebo and studies that compare drug to drug. And you're able to do some really interesting things and make head-to-head comparisons possible. They also agreed with us in that there isn't a class effect, and we can't say that a class of drug is effective. It's individual agents. But somewhat confusingly, in their analysis, they added together monotherapy studies plus augmentation studies, in particular with a drug called topiramate. Now, when you look at topiramate studies, there were a few monotherapy, a few augmentation studies. When you meta-analyze them separately, topiramate is no better than placebo. When you add them together, which I think is inappropriate, it does come out as being more effective than placebo. The difficulty there is that oftentimes in augmentation studies, the patients in the two groups might be on different base medications. Some might be on non-evidence-based medications that's augmented. Some might be on paroxetine or sertraline, and that's augmentated. So I don't think that we can draw conclusions from this study that topiramate is an effective drug for PTSD. I've got disagreements with the methodology. But one of the interesting things that came out of this one was that risperidone outperformed prazosin as an augmentation agent. And for this reason, we've re-emphasized it in the new TSW algorithm. Previously, we kind of de-emphasized risperidone as an augmentation agent because quetiapine was effective in monotherapy, and we made an assumption that it's going to be good in augmentation as well. And it's got far favorable side effect profiles compared to risperidone. But that's one of the changes that came from the update. Huang et al. Conducted another meta-analysis as well. Again, they recommended SSRIs and atypicals as a class, but only for severe or extremely severe PTSD. And they suggested atypicals only are effective in especially veterans. I disagree with this, and I think I've made the case that there is no class effect in PTSD drug studies. Raymond et al. Conducted a meta-analysis focusing on cannabis-based medical products, so THC containing products. But unfortunately, there is currently no placebo-controlled study, so we can't recommend cannabis-based medical products as being an evidence-based treatment for PTSD. There is a number of difficulties in conducting clinical trials of cannabis-based medical products, and unfortunately, a lot of the impetus to use them might be coming from more poorly designed, open label, poorly blinded studies. Yeah, there is hopefully some interesting research that'll be coming out in the coming years, especially from Project 2021. Then von Kannel et al. Published an interesting meta-analysis that caught my eye because they were looking at benzodiazepine use in people with pain secondary to acute coronary syndrome in a hospital setting. And they found that people that were prescribed benzos had a significantly increased risk of developing much more severe PTSD symptoms. And this is important for us to bear in mind because a lot of our patients have chronic insomnia or anxiety, and benzodiazepines, I think, get inappropriately used in chronic conditions like PTSD. So I've had this reflected in some of the guidance that goes along with the algorithm. Then I didn't include this in the written update of the literature, but I thought I'd share it here because it is quite interesting. So Mitchell et al. Published two very large-scale multi-center RCTs of MDMA-assisted therapy for PTSD in North America, mostly North America, in 21 and 23. These are the largest MDMA studies to date, and they compared MDMA-assisted therapy versus essentially inactive placebo-assisted therapy. And in the first study, they reported a 67% remission versus 32%. So 67% of people in the MDMA group no longer met the criteria for PTSD. Now, I haven't included this in the algorithm, of course, because it's a Schedule 1 Class A illegal substance that's very difficult to even research. But just to update you, last year, so I was the PI for the MDMA study in Cardiff. We were a multi-center study with sites all across the rest of Europe. We treated one patient, and it was very successful. And I'm currently in early development stages designing a follow-up study. So what I thought I would talk about now is an update from my kind of like my own clinical practice. So working in the traumatic stress service in Cardiff, I'm embedded within a highly specialized team containing many very experienced psychological therapists. And that's where I got the bulk of my referrals from. It's from people who have been accepted into the service that then would be on a significant waiting list. I think we're around 2 years at the moment. Or I would be referred people who are undergoing therapy. They've just started, but their symptoms are overtaking what they're able to do in therapy, and they might need some fairly quick work so that they can carry on with therapy. Or sometimes they have a treatment break from therapy for several months while they optimize the medications, and they can continue. Or the other way that I get referred patients is at the end of therapy, they've finished, but they still have some residual symptoms, and then I've got an open-ended period of time to do some work with them. Medications should be second line to psychological therapies, of course, but oftentimes with prohibitively long waiting lists, that's not the case. And I think it's the humane thing to do, not to ask someone to wait until they've done therapy, but to see if you can reduce the symptom burden they're suffering with evidence-based medicines. When I see a new patient, I will walk through the algorithm with them. I'll get it out and I'll talk through the different options, but in plain English, and always with very frank discussions over the common, notable, and serious side effects of every option as well. This helps a patient to make the decision in an informed way, helps them to, recognize their autonomy. And if someone's bought into something, they're much more likely to take it and to, follow your advice. So if I've got a patient who is maybe on a waiting list or they're on residual symptoms and time isn't a pressing factor, then what I always try to do is really just follow a simple, kind of 3-step process, which is try to establish them on one antidepressant from the algorithm. Um, I tend to favor paroxetine. I do probably prescribe paroxetine a little bit more than anything else. Once I've got them onto a medication, I get to the maximum dose. I always aim for the maximum dose if side effects are not getting in the way. If side effects are getting in the way, you might have to stretch things out a little bit. And then once you've got them to the maximum dose, it's just augment, augment. And triple therapy, like I said, with quetiapine and prazosin is probably the most common thing that a lot of my patients end up on. And it's a really good combination. It does seem to work fantastically well, especially with residual symptoms in a lot of patients. So I'll spend a bit of time talking through some of these ideas next, and then we'll have a look at the algorithm again, and then I'll just show you around the rest of the document. Sometimes in my clinic, I do need to move quicker. There might be a patient that's had 3 or 4 sessions of therapy. They've been on a waiting list for 2 years. They're starting to have significant symptoms, maybe with low mood or sleep or nightmares or hyperarousal or these sorts of things. And I'm trying to go in there and make sure we can work as quickly and safely as possible, so that they can then continue therapy when it's appropriate. So it's not uncommon for someone from the team to discuss someone in MDT and say they're really struggling with, low mood at the moment. What can we try to use? If I'm going to be using sertraline, it's got the gentlest side effect profile. That's nice and easy to start at 50 milligrams. I typically do increase on a monthly basis if side effects aren't too difficult. We should usually try to increase after 6 to 8 weeks. But if there's a time pressure and if the side effects are being tolerated well, then I typically increase 4 to 6 weeks. If I'm using paroxetine or fluoxetine, which are a little bit more associated with that kind of alerting effect with fluoxetine, but with paroxetine, it's maybe a little bit more bumpy in terms of the initial anxiety and insomnia getting on top of people. It's not uncommon for me to actually prescribe a very short dose of diazepam, and it might be 2 milligrams twice a day or 3 times a day to cover 14 days, and have a really clear conversation with someone that that's the only prescription for benzos that I'm ever going to give you. It's just to get you through the initial 2-week period of this medication. It's the only circumstances I would use a benzo for PTSD. If one of those has already been tried, then we move on to venlafaxine, and starting at 75, increasing in monthly steps of 75 typically works quite well. And I'm always quite careful to screen meds history, not just for other serotonergic drugs that are being prescribed. So your triptans, it might be a small dose of amitriptyline or maybe trazodone to sleep or something like that. But always ask about traditional Chinese medicines, over-the-counter drugs, and especially herbal things like St. John's wort. I'm always cautious when someone's on 2 antidepressants, but I would typically never prescribe my antidepressant if someone's already on 2 other serotonergic agents because of the risk of serotonin syndrome. So you've always got to be quite mindful. If someone's on an unusual, maybe traditional Chinese medicine, do look it up and see if it might have any serotonergic activity at all. Moving on to sleep then. Sleep is probably one of the most difficult symptoms that people have, insomnia. And I always start by counseling them on sleep hygiene techniques. So just to make sure things are kind of optimized, that they're sleeping in their bed rather than the sofa, if that's possible at the moment. Talking about screen times and all those sorts of things. There's lots of resources you can point people in the direction of. As mentioned, I really avoid benzos and Z meds. They're fantastically effective, largely safe, but for short-term use. PTSD is not a short-term problem, so I tend to avoid them because they create more problems in the long term. If nightmares are the culprit, if the person is able to fall asleep, but trauma-related nightmares are waking them up, then hypnotics aren't really going to do much good. They might, help them feel, sedated enough and relaxed enough that they can get off to sleep. But if you're prescribing hypnotics, if you're prescribing anything that I'm going to mention following on from here, and nightmares are the reason they're waking up, then you're going to need to use something to address the nightmare itself. So I found that if the person's sleep cycle is off, if they've lost their sleep rhythm, that kind of thing, if you need to restart their sleep rhythm, then off-license melatonin, 2 milligrams at nighttime, can be really quite effective for some people. For other people, it makes not the blind bit of difference, but for some people, it can be incredibly effective. And the side effect profile of melatonin is really quite mild. In this country, it is only available on prescription. It's licensed for younger people and older adults, but hasn't got a license for adults. Licensing is something that we can talk about maybe another time, but what makes a medication licensed is someone has, taken the case to regulatory agents who have then decided to license it or not. If no one takes the case to the agents, it doesn't get licensed. So if a drug company, maybe a manufacturer, doesn't think that it has a market, then it's not going to be licensed for that indication, even if it is effective for that indication. Melatonin is quite expensive, much more expensive than Z-meds and benzos, but for patients, it's not addictive, it's not habit forming. It works really well, but you have to take it at the same time every night. So if you want to be asleep by 10, you take it at 9, and it doesn't really interact with anything else either. So it's a really safe, effective medication that I've had a lot of success with. If a patient's sleep rhythm is lost, plus they do have some significant initial insomnia of longer than an hour, maybe, oftentimes it's hours and hours, then I might start them on melatonin and then maybe add in promethazine. And I've got some patients that have really moved from having, 3 or 4 hours sleep to having a full night's sleep on that combination that seems to work really well. Typically, I wouldn't go over 25 to 50 milligrams of promethazine. Ideally, it's short-term use, but for some patients, if you find that they get significant benefit that's outweighing any risk, then I have used that longer term as well. If someone is using melatonin longer term, then the advice is every 3 months have 1 week off, or maybe every 6 nights out of the week you take it, 1 night out of the week you don't. Just allows your natural melatonin levels not to be suppressed by the medication. And then after that, I would typically add in maybe quetiapine or mirtazapine or trazodone, but then being very careful about using too many serotonergic agents if you already have 1 or 2 things there. For nightmares then, so even though prazosin is really good evidence for reducing overall PTSD symptom severity, and some people it does seem to target nightmares the most, and then daytime intrusions, and then hyperarousal symptoms, prazosin has been extensively investigated in numerous RCTs and has been validated in the meta-analyses I've published as well as others as being, a safe, effective medication for reducing PTSD symptoms. And it would be a remarkable drug if it didn't have just a few annoying issues. The most annoying issue is the supply issue. So in terms of global supply, sometimes it's not possible for pharmacies to actually get it for the patient, either on time or consistently. The other issue with prazosin is sometimes the only doses available are 0.5 milligram tablets, which is a really big deal because the dosing regimen is an escalating dose up to around about 2 milligrams in the morning and 10 milligrams at night. You can go much above that if you need to, as long as blood pressure doesn't stop you. But if you're on 0.5 milligram tablets, that's 20 little tablets you're taking at nighttime, which I think is absolutely ridiculous. Prazosin has to really be prescribed BD as well. It's got a very short half-life. And if it's not being prescribed BD, you're probably not getting the most from it, especially for some of the spillover daytime symptoms. So on a pragmatic basis, if a patient has been taking prazosin and then the pharmacy can't supply any, we've often switched over to doxazosin, which is a sister medication. It's in the same family. It's structurally very similar and has the same kind of effect in terms of blood pressure as well. Doxazosin in the majority of people is better tolerated. You don't get as much maybe daytime dizziness, and you don't get as much of the initial severe postural hypotension because, of course, when you take prazosin or doxazosin for the first few doses especially, it can really drop your blood pressure very quickly. And if you're up and about walking around, you could fall over and hit your head. So I always instruct patients when you're taking these medications, the nighttime dose is taken when you're lying flat in bed. Medications on the nightstand, you take it, you go to sleep. If you need to get up for a glass of water or whatever, make sure when you get up, you take it really nice and easy as you stand up, just in case it does drop your blood pressure and you might fall and hurt yourself. So doxazosin, because it's got a longer half-life, it's only dosed at nighttime. And the dosing schedule that we recommend is 1 milligram at night in week 1, increasing in 1 milligram weekly increments up to 8, which is really nice and easy for the patient to follow. Because I've definitely had a few occasions where even though I've given a prazosin dosing regimen to a patient, they've come back and they've really got themselves in a pickle and they've not quite followed it and they're not quite sure, what kind of dose they've got up to. Doxazocin is a lot easier to follow. It's just 1 extra tablet a week until you're on 8 tablets. And then we can switch it over to, a bigger dose tablet, so you're not taking 8 individual tablets. Um, Generally, though, I tend to let the patient decide. I will typically explain prazosin has got the really good evidence base behind it as being effective. It's been used in PTSD extensively throughout the world. We know that it's a good, effective medication, but there are these tricky supply issues. The tablets might be really small when you get them. Doxazocin, we don't know as much about it in a research setting, but a lot of patients who have been on both say it's about the same or nearly as good, but it's a bit better tolerated. The tablets are easier to take. Which one would you like me to prescribe? We can try both, but which one would you like me to start with? More often than not, patients would say, I don't want to take 20 little tablets. I'll go for doxazocin instead. Another thing that you need to discuss with patients is these tablets, these medications, may have the effect of suppressing nightmares, essentially, reducing their symptoms. But for some people, it completely switches off the ability to have trauma nightmares or even dream. And that can be important if someone is on a waiting list about to go into therapy in a year's time or in several weeks' time, because that material is still there. And when you're in therapy, you may not know if there's more work to be done, if some of your symptoms are being suppressed. There's several options. You could either carry on taking the medication through the course of therapy and come off it at the end. And if there's still stuff there, then maybe you need additional therapy. You might need to come back and see the same therapist again. Another option might be to reduce and stop it before therapy, which might be really difficult because you're going to have a lot of difficult symptoms coming back up right before you're going to start a difficult new piece of work potentially. A third option, I think, is probably maybe the more sensible one would be discuss with your therapist and with the person prescribing it, and maybe have a plan to slowly reduce the medication as you started processing some of the daytime recollection symptoms. So when you know how the processing works, when you've formed a really good therapeutic alliance with your therapist, that might be the time just to start reducing the dose and see what is still there, what comes up in a nice gradual fashion. But of course, let the patient decide. And then for hyperarousal symptoms, so a lot of patients with complex PTSD might struggle with emotional dysregulation. Typically, I choose quetiapine. And when I'm explaining quetiapine, I go warts and all kind of in terms of what the common, notable, and serious side effects are, because people need to be mindful of a medication such as quetiapine, which at high doses over long periods of time increases the risk of metabolic syndrome, increases the risk of diabetes and these sorts of things. But then I kind of frame it in terms of the doses that we're going to start out on are going to be very small. And I've had some really good success with using just 25 milligrams, 1 tablet at night, increasing in 25 milligram increments every 3 or 4 days if needed, up to about 100 milligrams for the first month or two, and really let the patient have the choice as to when to take it. It might be 1 at night, 2 at night, 3 at night, 4 at night. It might be 1, 2, 3 at night with 1 in the morning, or 1 in the day at some point if they've got a difficult thing coming up. Sometimes that can be quite effective, just knowing there's an extra tablet they can take if they're going to do something that's difficult or overwhelming. Probably most of my patients end up settling on a lower dose, maybe 100 to 150 milligrams of quetiapine. And of course, an ECG and baseline bloods are necessary before starting quetiapine. But then, of course, don't forget to recheck the ECG once they've arrived at a dose that's working for them. So we'll just have another look through the algorithm just so you can see where those points are inserted. So if we move to the second line, you can see that where I've added what used to be prazosin augmentation, I have now listed as prazosin or doxazocin augmentation because of these supply issues. And of course, we've added risperidone there as well. In the back of the algorithm, we have the usual common adverse effects table, which is really useful to show to patients, I find, when you're sitting down and trying to find which medication might be preferable for them, especially with the antidepressants, then having a look at this will be really useful. And then we've, of course, got the monitoring requirements. That is quetiapine and risperidone on the algorithm. But when you start an SSRI, always warn every patient of every age group that there is a thankfully rare but serious side effect of increasing suicidal thoughts and acts when starting these medications. So if those thoughts do come to them, stop taking it immediately, talk to their prescriber or see their regular doctor to have that assessed. The way it works in my clinic is I typically see people face to face for about an hour on the first appointment, and then I give them more regular but much briefer telephone follow-ups where I can kind of cover these things in a quicker fashion. It's not always possible in different places where people might work, but I try to have briefer, more frequent kind of follow-up when starting a lot of these medications. I think that's the end of the talk. I'm very grateful for you for coming and listening. What I will do now is unshare my screen and have a look at the chat. If you want to access the Traumatic Stress Wales algorithm in Welsh or in English, you can visit traumaticstresswales.nhs.wales, and if you click on the Research and Improvement TSW prescribing algorithm, you will find the document there in English and in Welsh, and you'll also find a link to a much older talk I did in a bit more detail talking about the evidence base for different medications, and we'll upload this webinar to that page for you to refer back to as well. I'll just pop back to the chat and see if we have any questions there. So if anyone would like to pop a question in the chat, I'd be very happy to answer it for you. I can't see that there's anything there just yet, so I'll take it as I've answered all your questions already, which is fantastic. Is there evidence for corticosteroids for trauma, as there was a study by Prof. Bisson? Yeah, so this is more in prevention of PTSD. This talk is more focused on when people have a diagnosis of PTSD in terms of what medications can reduce symptom severity, but the corticosteroids research is more in the prevention of developing. I tend to use paroxetine, I think, because a lot of people have already been on sertraline, and paroxetine is maybe a little bit underused. People might shy away from paroxetine because of the discontinuation syndrome that you can get with it in terms of once you're on a decent dose, or even if you're on maybe just 20 or 30, if you miss a dose or a couple of doses, then you'll feel really rotten. You'll feel those sometimes flu-like symptoms, worsening anxiety, worsening insomnia, the dreaded brain zaps, the electric kind of shock feeling that's not dangerous but is very uncomfortable. So I think paroxetine is probably underutilized, and I tend to favor it as being a really good medication for PTSD if people can get over the initial bumpy first few days, the first week or two. What medications would you advise are not started in primary care? Really good question. So I know that medications like atypical antipsychotics are typically not started in primary care. There's no expectation that they are. They are medications that really should be started by secondary care or specialists. But I do know there are a great number of GPs out there that would feel comfortable in making sure someone's had an ECG and bloods and start them on a low dose of an antipsychotic. I would say that if someone is at the point of needing maybe an antipsychotic for their PTSD, they should probably be referred into a CMHT anyway, because they would need to access maybe a bit more specialist help. I would say that prazosin and doxazosin as well should probably be initiated by a specialist, and then maybe a GP could kindly take over a prescription if it is something that is going to be used long term. is there a difference in the type of trauma and response, i.e. abuse versus war trauma? So there's been a couple of studies where they've looked at different medications in different trauma type populations. We can't draw any conclusions from what's been published in terms of what medication might be more effective for different trauma responses. These medications across the board are useful, in any trauma group. How do you deal with reported sexual dysfunction as a side effect? I always counsel patients that it can occur. So up to half of patients who are taking an antidepressant or an antipsychotic might experience reduced libido, more difficulty with achieving an orgasm. And I always say that in the vast, vast majority of cases, when you reduce the dose or stop the medication, it goes back to normal. But very rarely, it has been reported that some patients continue experiencing sexual dysfunction even when the medication is reduced. You might do better on a drug like mirtazapine if they are having sexual dysfunction. For some patients, I've kind of exhausted the algorithm drugs, and we've gone like off algorithm to try and find an antidepressant. And I've had quite a bit of success with vortioxetine as being a medication with very low side effects when it comes to sexual dysfunction. Our GP practice is aware of the algorithm, as my experience is that mirtazapine is their first choice. So hopefully, yeah, a lot of GP practices should be aware of it. In Cardiff and Vale, I've done a piece of work where we have now officially incorporated the Cardiff version, the Cardiff prescribing algorithm from a few years ago, into the GP's computer system that they can refer directly to. I'll be later in the year updating it, so it's the TSW updated algorithm going into their computer systems. I've done a lot of work with GPs on a local and a national level trying to raise awareness of the algorithm. But if you could all be ambassadors for it and tell your colleagues around it, print out copies, leave in GP surgeries if you work there, that would be fantastic as well. What about those who are pregnant or experiencing PTSD symptoms? What medication would you prescribe? Really good question. So I would have a discussion with the pregnant person around the benefits and risks of being on medication if they're already taking something. Of starting a medication or of coming off a medication, and it's always a risk-benefit discussion around when a medication might be needed or not needed. Things like fluoxetine and sertraline are oftentimes used in those sorts of situations. Drugs like quetiapine, if you need to be on quetiapine, if that's reducing your symptoms and your potential risks, then that could be a medication that is continued as well. But involving a perinatal psychiatrist might be an idea if someone's got significant symptoms too. We use doxazocin in normal practice with BP management. Would you advise we still don't initiate even if we're comfortable with doing so? This means we would be referring people into CMHT only at step 2 of the algorithm. Really good question. If you're comfortable prescribing it and you're already using it for another condition, then I'd be happy for you to use it if it's reducing someone's PTSD burden. What I would wonder would be what other support might that person be needing? So if they're only in primary care, are they needing doxazocin and also needing psychological therapy as well? If it's the case they're going through some psychological therapy in primary care and they're on a medication like sertraline and maybe their nightmares are really significant, they can't engage with the primary care therapy, then adding doxazocin absolutely would be appropriate. And if you're comfortable doing it, I'd absolutely support that. I'm seeing lots of people on propranolol. Would you always look to stop this? No, I wouldn't. So propranolol is a really good medication for treating some of the physical symptoms of anxiety, and it can give people great relief for those general symptoms. There's no evidence it helps with traumatic stress symptoms. So there's no evidence that propranolol would work in the same way as doxazocin or prazosin. What I would say is you would have to, if you were thinking of keeping someone on propranolol and maybe using doxazocin or prazosin, you would have to look at saying what effect is this going to have on blood pressure? We're probably going to need to get rid of this one to use this one, or if we're going to carry on using this one, we probably can't use this one because people's blood pressure will just be in their boots. I provide annual teaching and a link on the draw. Oh, fantastic. Oh, from Sarah. Thank you, Sarah. For advice on treatment-resistant PTSD, can we get a second opinion from TSW? for consideration of ketamine or other novel treatments, study that you were recently researching. So it is possible to refer for second opinions. We rarely get them in through TSW, but that is one of the things that I can offer. In terms of ketamine therapy, that's not available, unfortunately, for conditions other than depression in the UK. There is currently scant evidence that it's effective in PTSD. There was one study we included in one of our reviews by Feder et al. That wasn't fantastically well designed, didn't have a psychedelic therapy component, no better than placebo overall, but it was probably sub-optimized, I would say. And unfortunately, there's no recruiting for any study going on in Wales at the moment for any psychedelic studies. So if that does change, it would probably be in the Cardiff and Vale area where the study would be conducted, and I'd be recruiting directly from our waiting list, I think. Thank you very much. I think we are approaching 45 minutes. If you've got any other questions, I'd be more than happy to answer them. Or if you like, I can pop my TSW isn't a clinical service. We are a quality improvement initiative set up by the Welsh Government to improve the health and well-being of people with PTSD and complex PTSD or at risk of it. And we work within the health boards across Wales. So we don't offer direct clinical services. Some of my TSW time, I work for the health board in Cardiff, in Cwm Taf and Swansea. And the way to refer a patient in would be through the usual referral pathways into secondary care for specialist trauma work. I'm just going to pop my email address in the chat here, just in case anyone wanted to follow up with any further questions. There is another Matthew Hoskins with 2 T's in his name. I've only got 1 T that works in IT, that gets emails from me every week. And he's really good and he forwards them on. So if you did want to email me, it's Matthew with 1t.hoskins@wales.nhs.uk. And yeah, if it's even medication advice, if you've got a difficult patient, I'd be happy to lend some thoughts there. But I think we are rounding out the talk. I'm not seeing any more. Oh, there we go. Thanks, Emma. I'm not seeing any more questions pop up. So what I might do is thank you all very much, Diolch. I'll draw it to a close there, and thank you very much for coming. Oh, has someone got their hand up? Not sure if someone popped their hand up then, and then maybe it went down. Nope. There we go. Okay, I'll draw it to a close there. Thank you so much for coming. I will wish you all the best and take it easy. Bye.